task for today was to just go over some the post myocardial infarction medical care. So this is going to be pretty straightforward, and these slides are essentially, and recommendations are essentially straight from the American Heart Association, the American College of Cardiology um, guidelines from the 2011 STEMI and the 2014 NSTEMI guidelines. So really straightforward. So basically, the kind of cornerstones of therapy for post-MI care revolve around a couple things. One is prevention of repeat thrombotic episodes, being repeat coronary thrombosis or coronary atherosclerotic events, the reduction in cholesterol, and then institution of guideline-directed renin, angiotensin, aldosterone antagonist therapy. So whenever we want to talk about prevention of thromboembolic events, we'll start with just aspirin therapy. So in all patients who have had an MI, the current recommendation, and there is a lot of active research in this area, but still the current recommendation from the American Heart Association is to continue aspirin therapy indefinitely. So the dose based on OASIS 7 is now 81 milligram, just a baby aspirin. So there's essentially no real indication for people that have had an MI to continue on any higher than 81 milligrams of aspirin daily. The other recommendation are that all people who have had an MI, at least the current recommendation is 12 months after an MI. So for a full year, they should also continue on a P2Y12 inhibitor, be it clopidogrel, ticagrelor, or prasugrel. The current guidelines have a preferential recommendation towards ticagrelor over clopidogrel based on the Plato trial. That said, this is also an area of active research, and this recommendation has been called into question. But nonetheless, at least at this time, through our guidelines, we should be on one of the P2Y12 inhibitors for 12 months following an MI. And you'll see these things may change in the future, and depending upon whether a stent was used or what stents were used, this certainly is subject to change in the future, but at least in 2020, based on guideline recommendations, it's a baby aspirin forever and a P2Y12 inhibitor for at least 1 year after an MI. Beta blockers. So beta blockers, these are the current recommendations in the slide. So oral beta blockers should ideally be given within the first 24 hours of an MI and continued thereafter. So there is some question as to whether this is continued indefinitely or not. That again is an area of active research, but essentially the way that it is recommended now is that you would start a beta blocker after MI, no matter what the person's ejection fraction is, and continue it essentially indefinitely. But like I said, that will be certainly an area of active research, how long you need to continue these things. Patients who also have a reduced ejection fraction, there are particular types of beta blockers that should be used. Those being the ones that are guideline directed for heart failure, being metoprolol succinate, carvedilol, or bisoprolol. So that's for people that have an ejection fraction less than 40%. People that have an ejection fraction greater than 40%, any beta blocker is acceptable. All right, so next, ACE inhibitors, ARBs, ARNIs, aldosterone antagonist inhibitors. So all patients, essentially all patients with an ejection fraction less than 40% post-MI, or in those that have hypertension, diabetes, or CKD, we should be putting all of those people on an ACE inhibitor or an angiotensin receptor blocker if they have an intolerance to an ACE inhibitor as a class 1 recommendation. Now, as a class 2 recommendation, you could say anybody who has had an MI should be on either an ACE inhibitor or an angiotensin receptor blocker. Now, aldosterone blockers, so this being aldactone or Clarinone, these are recommended in patients post-MI who have an ejection fraction of 40% or less and have diabetes or evidence of heart failure, who also have a reasonable renal function. There are different sort of recommendations for what a reasonable renal function means. There are strict definitions put in front of you in the slide in the heart failure guidelines, but essentially, practically, the use is in anyone with an ejection fraction less than 40 with diabetes or heart failure who you think that you can safely use an aldosterone receptor blocker. And typically, that is people that have a creatinine less than 2.5 in men or 2 in women. And this is far, far, far underutilized in current clinical practice. It is really one of the biggest holes in improper care post-MI that we see whenever we actually audit these things in both our own healthcare system as well as nationally. So when should these things actually be instituted? So ideally, these should be instituted in the hospital up front. So there is no doubt about it. The biggest bang for your buck is whenever you start these medications very soon after the MI. That's not to say if they get discharged not on these medications that we shouldn't start them as an outpatient. We certainly should, but there is no doubt about it. The biggest bang for your buck from renin, aldosterone antagonist blockers comes in really the first 24 to 72 hours of the initial hospitalization. This has been shown time and time again. Unfortunately, there is this kind of prevailing sort of incorrect approach that people will think, well, if somebody had a stent, they're at risk for contrast-induced nephropathy, and they got a diload, we shouldn't give them an ACE inhibitor, going into PCI or just after PCI, and that is absolutely incorrect. Although that, may have some ramifications for your likelihood of having contrast-induced nephropathy, the amount of people that actually go on to have serious renal dysfunction that is permanent related to contrast-induced nephropathy is extremely low versus the amount of people that will go on to have poor ventricular remodeling and heart failure following an MI is very high. So this becomes one of the risk-benefit sort of ratio balance that every provider has to make for every patient. But generally speaking, we should really be giving ACE inhibitors or ARBs and beta blockers within the first 24 hours of the event, and then aldosterone antagonists ideally within the first 7 days of the event. That said, should you get discharged off of these medications, you certainly should still start them as an outpatient. They still do have a role, but their biggest bang for your buck is to do this upfront in the hospital. Cholesterol management, patients that have had MI. So there's kind of a mixture of guidelines that we'll go over to really arrive at the correct, contemporary recommendations. So essentially, everybody that's had an MI should get a fasting lipid panel, and they should also be initiated on a high-intensity statin. So I have listed here in this slide what the high-intensity statins are, and those are atorvastatin at a dose of 40 or 80, or rosuvastatin, that's Crestor, at a dose of 20 to 40. So this is irrespective of the patient's cholesterol level, irrespective of the patient's age. The recommendation is high-intensity statin following an acute coronary event. So these guidelines or these recommendations come from the most recent ACC-AHA guidelines on cholesterol management and statin therapy. So all people that have had an MI will fall into this clinical atherosclerotic cardiovascular disease. That's clinical ASCVD at the top of this figure. In all of these people, we initiate and encourage a healthy lifestyle. Now, patients who have had an MI fall into the very high risk category on the left-hand side of this screen. So very high risk, how that is defined by these guidelines, are either multiple major events or one major and multiple high risk events. So one of the major events is a recent MI within the past 12 months. And then there were also these other high risk conditions. So since we're talking about, or a history of an MI, since we're talking about MI, we automatically end up on this side of the screen, you know? So automatically all of those patients should have a high intensity statin. And then we should, after a period of about 2 to 3 months, we should do a lipid panel. And if on that high intensity statin, their LDL is higher than 70. So we've gone back to target numbers. This is something that's changed. So 70 being the key number, not 100, 70. If the LDL is higher than 70, we need to do something else to make the LDL lower than 70. So reasonable approaches to that would be to add on ezetimibe, so that's Zetia, or to add on a PCSK9 inhibitor. So the current state of PCSK9 inhibitors and cost is that the opinion of the American College of Cardiology and American Heart Association is ideally to first try Zetia to lower the LDL to less than 70 on top of a high intensity statin. And that is basically an approach to contain costs. But in reality, you have to do something. And to go straight to a PCSK9 inhibitor is very reasonable based on contemporary data. But we do need to all practice within the realities of being conscious to the price that healthcare is delivered in. And that is why preferentially we'd add Zetia or ezetimibe in that situation if the LDL is greater than 70, but it is not data driven. It's not unreasonable to go straight to adding a PCSK9 inhibitor. And the final, key recommendation in post-MI care is that all of these patients should then be referred to cardiac rehab. So every patient who has had an acute myocardial infarction should be referred to cardiac rehab. And this is far, far, far underutilized in the United States healthcare system. There are, I know at our own institution, we have cardiac rehab actually inside of Ruby Hospital, and there are cardiac rehabs all throughout West Virginia. So I've never really seen an issue with access, for a cardiac rehab. The issue that sometimes people can run into is certain insurance companies in certain indications. But if you have had an MI, that is one that pretty much uniformly all insurance companies will cover cardiac rehab. So that's pretty much the easiest thing to get somebody into cardiac rehab for, is a history of symptomatic coronary artery disease. I'm a heart failure and transplant physician. Sometimes I have more difficulty with getting certain of my niche heart failure patients in, but this is one that's like a slam dunk, that anybody who's had an acute coronary syndrome should qualify for cardiac rehab. There are some recommendations below the actual class 1 recommendation for cardiac rehab about what the exercise can entail. But practically, the best way to do this is to essentially tell them to do, that they are able, in a case-by-case basis, to do, reasonable low intensity sort of walking during the time from discharge till they're actually able to start at a structured cardiac rehab program. And then once in cardiac rehab, each individual is given essentially their own unique sort of exercise regimen that is safe for them, most advantageous to them. The way that I describe this to everybody of my patients is, oftentimes people will be younger and relatively functional, say like, are you serious? Do I really need to do cardiac rehab? And I'll say yes. And I'll say, look at somebody like Michael Phelps or Michael Jordan, These are athletes at the peak of their, performance, and at the peak of, anybody in their fields. Do you really think that they also didn't have trainers to kind of push them to be better and get to the next step? And they certainly all do. And that's the parallel I'll draw, whenever somebody who's, say, 45 and otherwise like relatively active will say, do I really need to do cardiac rehab? Because not only is it help to kind of get them an exercise plan, but it also helps to initiate exercise in a safe way, that without, the confines of that building and that monitoring, is difficult to say it would be safe otherwise to just do independently. So that is it. Those are all my slides, and it really does. I mean, to me, it's a pretty straightforward. Oftentimes we give these presentations that last an hour, and there's just too much information, and you just get bogged down. They're unable to really make sense of what's what and what's important. But those are the key factors and the key kind of recommendations for post-MI care. Any questions?
Thank you so much for that. That was wonderful.
I did have a question regarding the cardiac. Is everything on hold right now with the COVID restrictions?
Yeah, that is a great question. That I don't know the answer to that, but my sense would be yes, most likely it is. I mean, this is kind of not MI specific, but just the way that I look at things during these during this COVID pandemic. I mean, essentially the morbidity, like the mortality risk of getting an ECG in somebody or getting a BMP, ordered. I mean, previously there was no mortality risk in getting a BMP, right? Or sending somebody to get an ECG. There is now a significant risk in doing one of these things. So the risk-benefit balance of each of these tests certainly changes dramatically. That I think that for some patients, I still may, pursue cardiac rehab, but I think that those practical recommendations, they're in the guidelines, that if they're not able to do cardiac rehab, about those target heart rate things I had in that last slide, which I'm sure we can circulate these slides as well, could be helpful, because this time, I think that I would be somewhat hesitant to even refer certain people to cardiac rehab, although there are others I certainly would refer. Now, functionally, if those cardiac rehabs are actually open and running, I don't know the answer to that, but I'd suspect they probably are not,
I didn't know if they were reaching out to their patients, to advise them and just encourage them. And, I know on the disease management side, we're trying to, to reinforce the social distancing and everything. But
yeah,
I think folks are getting, as things progress, the I guess panic is starting to set in.
Yeah, no, actually, you really bring up an excellent point that I will actually touch base with our cardiac rehab and see what they're recommending, because this is my own opinion, and this is not, endorsed by anybody else than myself, but I probably would not send a lot of people to cardiac rehab right now, but I would like somebody from cardiac rehab to contact these people and say, hey, these are things you could be doing at home. This is a safe way to approach this. That I think would be a good way. Now, whether that's cardiac rehab or that's the providers themselves in their telemedicine or telephone follow-up visits, that's a good question. But your question really did kind of bring up a bigger good point that I'm going to check into myself today, actually.
I just feel like some patients need to have some contact. It makes them feel like they're not just abandoned during the whole, social isolation situation.
Yeah, no, I agree. And I think that it is important that they do some form of cardiac rehab at home, because what you'll see, I'm sure, there are patients that I've seen the whole spectrum. Like I'm sure you have too, people that think, I had a heart attack, I better not even move whenever I go home. And then on the flip side, I've seen people that are like, okay, I'm going to start doing P90X now, and go nuts and want to do exercise. I'm like, whoa, that's not safe either. So they do need guidance. Just because they can't physically walk in and use the machines and be monitored, they still do need guidance. And I'm really not sure what we're providing right now. Myself being a I'm a heart failure and transplant doctor. I really don't do a whole lot of, truth be told, I don't do a whole lot of post-MI care per se, because they end up going to the general cardiologist and the interventionalist primarily for that. Although certainly I see a lot of people who have had MIs and have heart failure afterwards. So, but that's a great point, and I'm going to ask them what we're doing now for cardiac rehab.
Are there any other questions?
Yeah, just real quick, Dr. Bianco, thank you so much. You really clarified a lot and answered a lot of questions throughout your whole presentation, and I really appreciate the cardiac rehab information and also the information about aspirin there at the beginning. That was really important. I was wondering if there are any other medications that, maybe not cardiac medications, but any medications that should really be avoided post-MI, or anything that you should really look out for. I do understand that, diabetes and other comorbidities should be looked at, and hopefully tobacco cessation as well. But is there anything else that we might miss?
No, certainly. That is a very good point that I didn't really get into specifically with this, but absolutely healthy lifestyle and avoiding tobacco, and then treatment of comorbidity is tremendously important. I would say that, and actually just to answer the question directly, medications to avoid, some of these patients, I think that we always need to be cognizant of any of the kind of mood altering and psych drugs for their QT prolonging properties. That doesn't mean that patients shouldn't be treated for mood disorders, that are post-MI. On the contrary, it's actually tremendously important. And we do know that, once you've had a cardiac event like an MI, your kind of risk for having depression or anxiety certainly goes up. Some of these people will actually develop a PTSD sort of a syndrome after having some of these traumatic cardiac events. So there is no doubt about it that correct psychiatric and psychological care is very important. But sometimes we do see people that are on QT prolonging drugs that can become worrisome, particularly if these people also during their MI have had any sort of arrhythmias and get put on any sort of antiarrhythmics. So I would say that that's always one of the kind of worrisome thing that we look for, is particularly if you're on antiarrhythmics, particularly the potassium channel ones that tend to prolong QT anyway, that there's certainly synergistically, if you're on, say, Tecousin and then also are on one of the atypical antipsychotics, that can be a problem. So I'd always look there. TCAs in general, have been kind of associated with this like blanket increased cardiovascular risk in patients who have a cardiovascular history. So those ones in particular, we also try to avoid. So those are medications that, certainly I think deserve at least a second look on the med list. It doesn't mean, like I said, it's actually extremely important that if somebody's depressed and you don't treat their depression adequately, they'll have worse cardiac outcomes. So very important still to be treated, but I think I would look at those medications closely. Other medications to look at, oh boy, I just had something on the tip of my tongue. I was going to say, certainly the hormone type of, the hormone type of medications. And I'll tell you, really, the jury is still out here. Is my kind of take from the totality of the literature. Whenever we look at particularly things like testosterone replacement in men, I think that is something that I'm not saying that I have the answer for every single patient, but I think that's something that should be scrutinized in any patient that's on testosterone, any male, that really is this truly indicated in this patient anyway, and then if it is not truly indicated, are we, I'd just have a frank discussion with the patient. And it usually starts with, I'll tell you, the literature, and the literature is very conflicting, and is not great here, but I think that we really need to at least have a discussion about this and consider it. Similarly with hormone replacement therapy in females, particularly postmenopausal females. That is an area to me that's even more complicated than the testosterone area. And at the end of the day, I really don't have great recommendations for you, except for it deserves a second look and shouldn't just be breezed through on the medication list. And oftentimes, I find that patients will have, their symptoms that kind of warranted getting put on these medications. If you really put it into the terms of, we're not really sure, but another one of these events could potentially be life-threatening. Sometimes patients will say, yeah, this thing wasn't even really helping me that much anyway, and we'll get rid of it. Now, is that always appropriate? I don't know, but at least, I think that most of the time, I wouldn't advocate stopping any clearly efficacious medication, from a mortality perspective at least, but medicines that are kind of designed more to, relieve hot flashes, or maybe, give these men this kind of sensation of more vitality. I kind of call into question a lot of the indications for these medicines anyway in the first place, but certainly in somebody that's had an atherosclerotic event, I think they deserve at least a discussion. And then, not really directly answering your question, but just getting onto the other sorts of comorbidities, diabetes care, smoking cessation, tremendously important in this group. There was a period there where Chantix, there's a question of Chantix and its cardiovascular safety, that I think that this is all behind us now, that certainly we still recommend Chantix in people who have had an event, or really any other form that the patient wants to pursue of trying to quit smoking. Diabetes care, tremendously important. We now know that certain medications for diabetes, comorbid diabetes, cardiovascular disease are very important. So whenever I see patients on, sulfonylureas or TZDs, things of this nature, I typically am saying, boy, you have cardiovascular disease. We know that, certain medications for diabetes are better in people that have had cardiovascular disease. So in particular, at least my kind of approach is patients who are more on the heart failure sort of spectrum of things, SGLT2 inhibitors, but probably anybody that's had cardiovascular disease, that's a reasonable place to go is with SGLT2 inhibitors. And then patients that have more of the atherosclerotic type of events, like MI, strokes, etc. GLP-1 medications, we saw in the LEADER trial with liraglutide, certainly there were beneficial effects for people who had more atherosclerotic type of events. Although we don't really have the best data for cardiovascular efficacy in metformin, we do have good safety data. And I think just because of, the overall multiple kind of theoretic good things that metformin can do from a cardiovascular and metabolic perspective, I still always have that as my kind of foundation medicine in type 2 diabetics. But it's typically my approach, and I think this is pretty much in line with the ADA and the ACC-AHA approach, is a foundation of metformin, and then to consider the addition of SGLT2 inhibitors or GLP-1. But I think that more and more other medicines like the sulfonylureas, TZDs, are kind of falling out of favor. I'm not saying that necessarily they have a danger, but whenever we know that there are clearly meds that have efficacious, efficacy data, it's hard for me to rationalize using one that doesn't have that good data behind it.
Thank you so much. That was incredibly helpful. I really appreciate it. And I really appreciate hearing about metformin. That helps.
Oh yeah, no. And I'll tell you, so I'm a heart failure doctor, and I'd say one of the biggest kind of misconceptions that we had as practitioners years ago, and still kind of is out there, but I think less and less now, is this worry with metformin and heart failure. I mean, the amount of people that you will see with worsening heart failure and that has in part to do with poor glycemic control and obesity, etc. I mean, there's tons, right? The amount of people that have walked into the office with lactic acidosis secondary to having heart failure and metformin, I bet you none of us have ever actually even seen that. I mean, I think that is something that got really way, misperception that happened about a decade ago that still kind of lingers in the community. Also CKD, the recommendations now, I can't rattle them off, but they are dramatically different than they were, I know whenever I was training in terms of which patients you can and can't use metformin in. So, at least my understanding is I believe down to a GFR of 30, there's like no problem. I think between 30 and 45, maybe the recommendation is to at least like raise an eye to metformin, but that doesn't mean you stop it. It's potentially dose reduction. But GFR greater than 45, don't even blink an eye, give them metformin, that's fine. And heart failure, I can say, a significant proportion of my diabetics who are stage D NYHA4 on their way to transplant, I still have on metformin, as do all of the contemporary, people managing this advanced heart failure throughout the country, and there's no issue with that.
Perfect. That's so helpful.
So we did have a question come in. So for patients post-MI, would you recommend also doing a stress test? And a lot of questions they get from their patients are, when can I return to work? And are there limitations on what I can do at work?
Yeah, okay. So the best way that I really approach this, this is truly a data-free zone. I would also lump into, I get asked frequently about sexual activity post-MI or post-heart failure or hospitalization. This is essentially a data-free zone, or the data that's out there is really not great. So the approach that I personally do, and everybody, is just, common sense sort of stuff. And then I really encourage cardiac rehab in every single patient, because I always tell them that in addition to, this is kind of like Michael Phelps has a trainer to get to the next level and to be better, you need this cardiac rehab. Also, the thing is that this provides like the way to safely get back to activity. In addition to just getting better, also how to what is safe for somebody. So I really do rely on cardiac rehab a lot in that same sense. But otherwise, I just try to use common sense, and really there is no data behind this. There's no science behind this. But I do think that having these blanket statements like, nope, nobody can go back to work until like X weeks, nobody can have sex until X weeks, that's got to be wrong. You have to take this on a patient-to-patient sort of basis. Now, stress testing post-MI, the biggest role for stress testing post-MI are patients who have not had an invasive strategy, so have not had a coronary angiogram. If you do a conservative approach prior to discharge or shortly thereafter, to do a low intensity, like a modified Naughton or Naughton type of stress test, is very reasonable, looking for residual ischemia, and that can drive you to actually say, hey, maybe we do need to actually cath this person. Short of that, there's not a lot of data on doing stress testing. Now, there is some older literature about stress testing kind of during cardiac rehab, again, to determine safe activity. But again, I just kick that right back to, that's where cardiac rehab can help. Although, as one of the other participants pointed out earlier, we're in a tough time right now because cardiac rehab is really, probably on hold right now. So I tell you, purely from a guideline and data-driven perspective, we don't have any, and we don't have any great recommendations other than the ones that I presented earlier. So it's just common sense approach.
Absolutely. Thank you so much. That was excellent. Were there any other questions out there for Dr. Bianco?
All right. Well,
Yeah.
thank you. And please, if it's absolutely, you have my permission, I'd encourage, if you want to give those slides out that I sent in earlier, that'd be perfectly fine.
Yeah, absolutely. So I usually send out a recap email after sessions, and I'll include the slides for sure. We also do post our sessions onto our YouTube page, which I'll have a direct link to that as well in the recap. So just a quick announcement, our next session is on April 17th, and Monica Thomas is providing our didactic on VADs. So keep an eye out for that. Thank you again so much, Dr. Bianco, for making it today. We really appreciate it. So we'll see you all next time. Thank you.
All right. Have a nice day. Thank you.
Thanks.
Bye.
Stay safe. Bye.
Thank you.